asthma management guidelines change all the time. So the question is, can you get this asthma MRCP question right? So let's get into it. A 22-year-old man who has asthma comes to clinic for review. He's currently treated with fluticasone 125 micrograms and salmeterol 25 micrograms, 2 puffs a day, using a spacer. He's currently waking up 2 to 3 times per night with coughing and is having to use his salbutamol inhaler at least 3 to 4 times per day. There is minor wheeze on auscultation of the chest in clinic, and his peak flow is 450. His predicted is 575. Now, just looking at this picture, we can make some decisions. One, this man is not having an acute exacerbation of asthma. He's having uncontrolled asthma that we need to escalate treatment for. So the question is, which of the following is the most appropriate next step according to National Institute for Healthcare and Excellence, Care Excellence at NICE guidelines in his asthma treatment? So, in my videos, in my MRCP videos, we go over guidelines and the latest guidance on how to manage diseases, but we also stress the importance of having the right clinical decision making and using clinical reasoning for elimination. And that's what I will try and explain using this question. So before we go through any of the guidelines, before we talk about asthma, let's try and figure out the answer without knowing the latest guidelines, okay? So I think the preparation is two-part. Part of it is improving your medical knowledge and reading, and that's what we're focusing on partly. The other part is knowing how to approach the questions, okay? And this is as important as actually knowing the actual medicine, knowing what the question is asking for and how to answer it. So let's look at this question. As we said, this is not an acute exacerbation of asthma. It is a poorly controlled asthmatic that we need to escalate the treatment to. So from the choices, we can eliminate D, oral prednisolone, because oral prednisolone is used in asthma exacerbations. Okay, so we can remove D. Or we can also eliminate oral theophylline, because this is a very specialist medication. IV theophylline is used in exacerbations but under specialist advice. Oral theophylline can also be used in asthma management, but again, it's lower down on your list of things to do first, 4th line, 5th line medication, and we're not there yet with this patient, so we can eliminate E as well. Now, let's look at A and B. Now, A is saying we're going to increase the steroid, the fluticasone, to 500 micrograms twice a day. Right, so we're doubling the steroid. And the second choice is that we're doubling the salmeterol. Now, fluticasone is steroids, as you know, and salmeterol is a long-acting beta agonist. Now, if we're going to increase the dose of the inhaler, the LAMA and ICS inhaler, we're going to increase both doses. So the fact that their choices separately means that both of them are wrong, right? We wouldn't increase the steroids without the LAMA. We would increase the LAMA without the steroids. So just using elimination, we are able to get to the correct answer, which is C, oral Montelukast. If you want more of strategy regarding how to approach questions, I'll put one of my other videos up at the end of the video, and you can have a look at me trying to do this with 5 MRCP questions, and it's a skill that's really worth working on. So let's actually get into the medicine and look at the latest asthma guidelines. So diagnosis of asthma has changed. We're going more towards objective tests. Okay, so to diagnose asthma now, we use FeNO and spirometry. So FeNO is uses nitric oxide, one of the types of nitric oxide called inducible nitric oxide synthase. These levels rise in inflammatory cells, especially eosinophils. So high levels of nitrous oxide correlate with high levels of inflammation. Now, all patients more than 5 years old, where we clinically suspect asthma, should have objective tests. Now, the objective tests are FeNO, as we discussed, and for FeNO to be positive, you need more than 40 parts per billion of the nitrous oxide, and the other more traditional way of diagnosing asthma is by spirometry, where we see an obstructive picture, where the FEV1 to FVC ratio is less than 70%. We also need reversibility, where we give a short-acting beta agonist, and we need to see an improvement of FEV1 by 12% or more than 200 mol of FEV1 to establish that there is a response to bronchodilatation. Now, at the same time, when we're thinking about asthma and objectively testing for it, we need to check for occupational exposure. It's really important to check peak flows for these patients during work and during weekends where they're not working to see if there is any variation. More common occupational exposures are isocyanates, such as spray painting or molding, using adhesives, platinum salts, soldering, flour, resins, proteolytic enzymes. So anyone who's doing any factory work or is spray painting, or it's very important to ask about occupation. If there is a concern about occupational exposure, then you should refer to a respiratory specialist and talk to occupational therapists in this regard. Now, the other thing that's very important is smoking. Now, this includes cigarette smoking, cannabis smoking, and also secondhand smoke. So exposure to someone that's smoking in the house or working in a pub or somewhere where there's a lot of smoke. So now we get to the real deal, which is how we manage asthma. Now, if we have a look at this figure here, this is the latest guidelines, which is a joint BTS NICE and SIGN guidance on how to manage asthma. Before we go into the details of this, I would like to let you know a bit about MRCP updates. Now, the MRCP question and the explanations here are from MRCP updates. You can subscribe using the link below and you'll get a 10% exclusive discount. There are thousands of past paper questions with elaborate explanations and an online textbook that's ideal for visual learners. I personally used MRCP updates for my MRCP Part 1 and Part 2 preparation. It's a great preparation resource and I do recommend using it 3 to 6 months before your exam. If you're unsure how to start your preparation and you need some guidance, I'll put 2 videos on the screen at the end of the video detailing what to do and how to prepare for MRCP Part 1 and Part 2. Now let's go back to our asthma guideline. Now this is the latest combined BTS NICE and SIGN guideline on management of asthma. Now looking at the figure, it looks a bit complicated, but we'll work through it together. It's actually not that complicated. So newly diagnosed asthma in people aged 12 or over, we start AIR therapy, which stands for anti-inflammatory reliever therapy. And now this is simply a combination of inhaled corticosteroids and a long-acting beta agonist. Now we used to only give SABA, short-acting beta agonist. Now this has changed. Now the main reasoning behind this is, one, the anti-inflammatory effects of inhaled corticosteroids and the relative safety, and two, the LABA and SABA, the onset of action is actually very, very similar, and the LABA stays for much longer. So it makes the effect of it lasts for a longer period. So in people who are newly diagnosed and who are not highly symptomatic, we offer a low dose AIR therapy. Okay. Now, in those that already are on a SABA, so those that have been on the previous guidelines and only have one SABA inhaler that they use for as reliever, those should be changed from SABA to AIR therapy as well. Now, if the asthma is uncontrolled on the AIR therapy, then we go to a low-dose MART. Now, what do we mean by an uncontrolled asthma? This is very important. Uncontrolled asthma, if we look at the bottom here, is any exacerbation requiring oral corticosteroids or frequent regular symptoms. So using a reliever more than 3 days a week or nighttime wakening 1 or more times a week. Okay, so this is very clear what counts as uncontrolled asthma. Now, if we look at the top here, we need to take into account and address possible reasons for uncontrolled asthma before changing or starting medication or adjusting medications. For example, is there an alternative diagnosis of comorbidities? If there's not good adherence, or if there isn't good technique, if they're not using an air chamber, are they smoking? Do they have any exposure to secondhand smoke? Is there psychosocial factors or seasonal factors or environmental or occupational factors? We need to look into all of these. Now, if we don't have any of these and it's still uncontrolled, then we don't go to a low dose MART. And if that doesn't help, we go to a moderate dose MART. Now, what do we mean by AIR therapy and MART? And what is a low dose and a medium dose? These are really good questions and they're often not easy to find. Now let's have a look at this table together. I've used Symbicort here as an example. Now, AIR therapy and MART are the same. The only difference is AIR you only use it as a reliever. So it's the same inhaler. A common one is Symbicort. Now, Symbicort 200 by 6 micrograms. This is a combination of 200 micrograms of budesonide and 6 micrograms of formoterol. Okay. Now this, if you start air therapy, only use it as a reliever. You tell them use 1 puff up to 12 times a day if you need, maximum six puffs at one time, like with like a few minutes in between, and you only use them when you need. Okay. Now, if this is not controlling the symptoms, then we go to a low dose MART, which is the same steroid, the same inhaler, but regularly. Now, the starting dose for a low dose MART is 1 inhalation once or twice a day. So if we use Symbicort, for example, here, it would be 200 by 6 micrograms, 1 puff once or twice a day. Now, if this doesn't control the symptoms, then we go to moderate dose MART, and these are the same inhaler. We stick with the same Symbicort inhaler, but we increase it to 2 inhalations twice a day. And this is the maximum dose that we give. And if that doesn't control the symptoms, then we need to add on more treatments, which we'll get into in a bit. Now, before we do that, I just want to pull up some other common inhaled corticosteroids. So the common ones are really 3. Beclomethasone, budesonide, and fluticasone. And conversions between these can be annoying. Basically, beclomethasone and budesonide are the same, and fluticasone is twice as strong. Okay, so 200 micrograms of fluticasone is equal to 400 of budesonide and 400 of beclomethasone. Now, if we go back to our question, the patient was on 125 micrograms of fluticasone, 2 puffs twice a day. So this is 250 micrograms twice a day, so 500 micrograms in total. So he was on 500 micrograms of fluticasone, and looking at our conversion chart again, 500 micrograms of fluticasone would equal around 1,000 micrograms of budesonide. That, if we look at our moderate dose MART of Symbicort, is 200 micrograms of budesonide, 2 puffs twice a day, so it's 800 micrograms. So it's even a bit higher than our moderate dose MART. So they are on a high dose of steroids. That's why we go to adding another medication, which in our case was Montelukast. So let's go back to our guideline to just see what we do if our MART is not controlling the symptoms. So you start a low dose MART, Symbicort, 1 puff twice a day. It doesn't control the symptoms. You go up to 2 puffs twice a day, and still the symptoms are not controlled. Then what you can do is you add on another medication. You either add on a leukotriene receptor antagonist, such as Montelukast, or a long-acting muscarinic antagonist. So you start one of them. So for example, in our case, we've started Montelukast. Now, if we see this patient again in 3 months, and they've gotten better with the Montelukast, then we'll continue it. If they're the same, then we can add on the LAMA. So they're on a moderate dose of MART, Symbicort, 2 puffs twice a day. We've added Montelukast, and now we're adding a LAMA inhaler as well. If one of them is not working, so if the Montelukast doesn't help at all, then we can stop it and start a LAMA instead. So this is basically our asthma guidelines. If at that point the asthma is not controlled, then we can refer the patient to get more specialist respiratory advice. We can think of more add-on therapies, things like the theophylline that was in the question initially. Alrighty, so that's the latest guidelines on asthma, chronic asthma management. Now, if you like the video, please don't forget to like the video and subscribe to the channel. On the video, I'll put 2 other videos. One is my guidance on MRCP Part 1 preparation, and the other one is my guidance for Part 2 preparation. And on the other side, you'll see the video where I go over how to approach MRCP questions with the right clinical decision making. All right, thank you guys, and I'll see you next time.